Welcome back, ladies and gentlemen. Please do take your seats. Small items of luggage should go underneath your seats, please, and only the trolley bags should go in the top compartments. So we're now going to make a start and changing from talking about cancer networks to something quite similar, but capacity building. And what is capacity building? Capacity building is much more than training. It's much more than training and education. It's helping infrastructures or networks to grow and develop. And OECI was recently involved with the International Agency of Research on Cancer in a capacity building venture in the Baltic state of Latvia. And we're about to hear both sides of that equation. We're about to hear from Professor Mef Nilbert, who was our leading consultant on that project, and from the representatives from Latvia itself. Really pleased to welcome Andrei Polkins from the Riga East University Hospital. But let's start with Mef on the project in Latvia.
Thank you, and thank you very much for the possibility to present here together with Andres. So from the OECI perspective, first of all, this is work I did together with Simon Oberst and Harriet Blowers. It's a DG reform project where the OECI was a subcontractor to IARC, and the aim was to provide advice, recommendations, drafting a roadmap to improve cancer care coordination and screening in Latvia. So a little bit on the background that Latvia was lagging behind compared to other EU members on several performance indicators. The registries had been functioning but had stopped functioning, so there was no real functioning cancer registry. Screening was also lacking several components and had quite low uptake rates. The policies for cancer control were not fully coordinated, and the collaboration between the different institutes, universities, university hospitals were also very limited. And as yet, but it's, as you will hear, coming, not yet an accredited cancer center. But the Ministry of Health was very committed to improve the situation with a focus on cancer registration, on screening, improving the uptake of screening, and also achieving more comprehensive cancer care. So what did we do? And now this is a presentation sort of from the OECI perspective. How did we go into this work? And I think that this is relevant also for the very big tasks we have upcoming for the CCI for EU, where you will hear more about this later, but where we, as OECI, will come into a number of countries and provide this type of support, advice to help develop or build capacity. So we visited the territory from a cancer perspective and really put the patient as our partner and in focus and ask what is best for patients here in Latvia. We started with collecting basic information and then asked what is it that need to be interconnected here, and also what are the barriers to that type of interconnection. So some key figures. This is, as you can see, this is data largely from the EU Cancer Inequalities Registry, which we did not have access to at the time, but it came, luckily, during the project. High cancer mortality rates compared to other EU countries. Regional differences, which is, of course, seen in many countries. Quite low investment in cancer care in the country, and then a high burden of cancer, and that combined with limited availability of resources. Furthermore, quite red or yellow-red there when it comes to the risk factor profile, several high risk factors. Participation in screening was lower than in other EU countries and also showed quite a large ranges. And the number of approved drugs that are not refunded or have to wait long for refund was higher in Latvia than in many other countries. So there were some real big challenges here. So we collected this team of three, me, myself, Harriet, and Simon. We went to visit. Our first visit visited all the university, the two different universities, the university hospital, there are also private research institutions, This is a picture from the very old and beautiful Pulstradis University, where there's a lot of breast cancer, for instance, is treated there. And to the right, the big Riga East Hospital. That was the first visit to sort of map the landscape. And then we started thinking about what are gaps here? What are the provisions in integration that we need to work with? And then not we need to work with, but we work together with the hosts in Riga or in Latvia to discuss how can this be built. So we introduced this map, which I think is well known to most of you, the CCN, the CCI map, and discussed that this is what we want to achieve. And then also did that from a sort of Latvian perspective. How can we build this comprehensive cancer infrastructure on a country level, that it has to involve the public health and primary care. It's everything through the cancer process. It's also research and innovation, education and training. So it's really a quite comprehensive and broad area. We then held national workshops on radiotherapy, precision medicine, clinical trials, palliative care, together with different providers from the different universities, hospitals, research institutions, also from local hospitals further out in the country, and discussed that you can see here these many things. Fantastic dialogues. It's so inspiring when staff, researchers, healthcare leaders come together and really try to think about how can we improve coordination. We talked about MDTs, developing virtual MDTs for the country, and as you can see, many other issues. And we were also served fantastic food there, I have to say. That's on the lower picture. At this second meeting, we also met with several agencies and ministries to sort of understand the questions like e-health, integration, data capture, the barriers to approval of medicines. So that's the way we worked. That brought us to the third visit. Each visit was a couple of days, where we really aimed to sharpen and validate the actions we proposed that also came out of the workshops, and to draft the roadmap. We also held a stakeholder forum and also reported back to the ministries. And I should have said that while we focused on this infrastructure building, the capacity building for the cancer research and care networks and patient pathways, there was parallel processes from the IARC that focused on the screening and also on re-establishing a cancer registry for Latvia. So these are the summary recommendations, and I'm not going to go through them, but in short, we gave recommendations on the sort of whole patient pathways, focused on the multidisciplinary networking, which means joint establishing and also then comparing the patient pathways, achieving MDTs across country, the need really for data access and so steer with data. They have really strong research in several areas, but perhaps not so interconnected with healthcare. So that's also one of the suggestions. And then how they can continue the good work with patient involvement, patient partnership, and then some words on HR planning, etc. So out of that, we established this roadmap for Latvia. From these different perspectives, but also prioritizing, of course. When you do this sort of strategy or roadmap work, capacity building, I mean, you also need to understand that there needs to be some sort of priorities and also a sort of stepwise, a gradual development of the key gaps. So I will stop there and really want to express my deepest thanks to all the staff, researchers, patients from Latvia who were so deeply involved and engaged in this work. And of course also both the IARC and the OECI teams. I think what we can learn for OECI to bring on into the CCI for EU is that start with this regular and informal contacts. You need to build this sort of team together to have the same view on what's going to happen here. Build a culture of collaboration between our consultancy team and the local team, but also within, of course, the country or the different healthcare institutions. Patient-centeredness often, always probably, helps when we run into issues. So think about the patient pathway. How would this look from a patient perspective? It really opens up some of our discussions. And then what we had here was really a bottom-up and a top-down sort of buy-in and commitment to the project, which made it easy, relatively easy. And then, of course, work with identifying the key gaps and barriers. And finally, of course, negotiate agreements. Are the ministries, are the healthcare providers, are they ready to actually support the further development? Because a roadmap, just as an improvement plan, is sort of just the start. So with that, I will leave over to Andres.
Thank you. Right. Good morning to everyone. So, thanks to Professor Mev Gilbert for a nice introduction. And today, so just my speech will be about the reflection of the project ICCCS in Latvia. So just a brief overview, population is 1.88 million, and so far we are aware about of 80,000 cancer patients active. About 12,000 new cancer patients are diagnosed yearly, and there are about 6,000 patients dying with oncology. And the fact that approximately 90% of cancer patients are seen in 2 main university hospitals fulfills with the Beating Cancer Plan aims to ensure that 90% of eligible patients have access to such centers by 2030. The ICCCS project has worked in areas that has to be improved, but it was not limited to. So actually, the malfunction of the cancer registry, low cancer screening coverage rates, and insufficient data digitalization. Moreover, so there was some areas that have to be improved, and it was highlighted. There was a lack of Ministry of Health managed national state research program. They were not determined the minimum standards in cancer care and the minimal volumes. We didn't have a cancer center or comprehensive cancer center, and there was cancer care inequalities nationwide in the EU. Of course, there was, again, another issue with the insufficient palliative care capacity and non-standardized MDT protocol, lack of effective information system, and there was very low investments into the healthcare. Well, in 2021, Latvia, so there was a parallel project applied for OECI membership. And during the ICCCS project, so we realized that the comprehensive cancer care, it just goes beyond just one center or one comprehensive cancer center. So it should include all levels of the management, so starting from the governmental bodies and finishing with a single specialist, single nurse. So therefore, we started the accreditation process, which we believe should be the core of this cancer patient management. And the other university hospital has applied for the, became a member and is getting ready for the accreditation process. So hopefully in the near future, we'll get 2 cancer centers which will be connected by the network. Regarding Riga East University Hospital, just a month ago we finished self-assessments, and we think that we complied in 66% of all requirements, and 34% the answer was no. So therefore the improvement plan has been created and sent back to auditors, and we are waiting for the decision whether go or no go. In the case of go, hopefully we'll get site visits in September. If no go, then we'll have another 6 months for the improvement works, and then we'll go for the cancer center accreditation. Of course, the main, the target is to accredit a comprehensive cancer center, so probably we need at least 1 in Latvia, but it will be enough probably. So, as a response to ICCCS project recommendation, Center of Disease Prevention and Control, has started activities which were related to the screening. So submitted recommendations are approved amendments to the Center of Disease Prevention and Control and NHS regulations, clearly defining the division and function between them. So there is ongoing creation of the screening committee, and the Center of Disease and Prevention and Control, since the October 2023, became the responsible body for the screening program. The screening organization, financing and resources, so there is still ongoing works on the referral pathways, developing and implementing a training program into the plan and well-organized training course for screening purposes. And there was some additional budget allocated for the training for screening service providers. Some more recommendations are taken in mind, and some of them are going, so to develop and approve the latest evidence-based guidelines and protocols for all cancer screening programs, conducting regular reviews of guidelines and protocols, and establishment of the system that measures and evaluates the quality and compliance of screening services. There have been ongoing actions for raising the awareness and the screening, so trying to strengthen the system of invitations, implement an invitation reminders system, which is going to help probably with the uptake numbers, develop written guidelines for communications with the screening guidelines, and inclusion of colorectal cancer screening in organized screening system with invitations, because before that it was just responsibilities of the GPs. So far, we were facing very low screening coverage rates and the program results up until 21, which is fulfilled with the project beginning. And since then, so you can see, so we managed to turn the curve up. And in cervical cancer and colorectal cancer, we almost managed to double the screening uptake rates, so which I think is great success. Finally, so there was some recommendations on cancer registry. So the new population-based cancer registry has been developed and it started to work. Actually, why new? Because it was renewed and it was malfunctioning from 2017 because there was some transition from one authority to another authority. So there is still ongoing work on new cancer screening registry developments at this point, so it's in the implementation phase. And there was some ideas of creating clinical cancer registries on the base of clinical universities, hospitals, but it will be possible with the functional IT systems later. So the achievements, as I mentioned, so the population-based cancer registry is live from 2nd of January this year. So it means there are teams that collecting the prospective data ongoing, and the other team is collecting retrospective data from 2017. So at some point, so we'll get fully functional cancer registry. There are new regulations from this year, January, so data and laboratory tests are integrated into eHealth system. And standardized MDT protocols and the discharge letters are implemented in the Riga University Hospital information system, including all required data for the cancer registry purposes and also OECI accreditation indicators, so the mainly quantitative and qualitative indicators. There was a pilot project at Hospice at Home, and it was highly evaluated by the ICCCS project experts, and therefore the mobile palliative care teams are available 24 hours after referral nationwide from 1st of January. So that means that all patient in needs can get palliative support at home, covering all patient needs at home, including symptomatic treatments, nutritional support, rehabilitation and supporting equipment, psychological support, palliative specialist consultations, etc. So, and what we noticed, the decreased number of hospitalization for palliation, and I think it's a good sign. So regarding data management, it's been highlighted as a main issue of cooperation between the hospital and exchange with the patient data, and there was a great step forward. So we signed an agreement on data exchange between 2 university hospitals, and so far, so it's currently just radiology, but there is a strict plan for patient health records and laboratory data. And later on, so we are planning to add to this network both regional hospitals as well, so the data will be comprehensive. And currently, until end of this month, the outsourcing service provider Ernst & Young is doing an assessment of the cost of comprehensive hospital information system that should be implemented. Well, it should be introduced in 3 university hospitals, 2 regional hospitals. So there are actually 6 solutions that are being evaluated, 2 local ones and 4 international. So the Ernst & Young will also provide description of the specification for the needs of this system. So the 3.5 million has been allocated for the needs of the information system, but of course we know it's not sufficient, but we wait for the Ernst & Young report and then we'll know where to get more funds, and it's planned to get some from the EU funds and one part as a part of the budget. To sum up, there was some implementation of the recommendations from the ICCCS project, the government's legalization. The roles and responsibility authorities has been defined, which is very important between NHS and between CDPC. Screening, test and diagnosis guidelines are in process and maturing to disease prevention control centers. Even the project has finished, but we are still cooperating with the Netherlands to improve the screening process. Organization, funding, staffing, additional funding allocated for the cancer beating policy, and there was since last year available budget for the new project NHS Innovation Laboratories for innovative services in healthcare, and currently 76 projects applied, and majority of them related to oncology care. So raising of awareness, there have been involvement of government representatives in public awareness activities, workshops led by academic sectors representatives in order to consider reorganization of different processes. So actually conferences, workshops, just to raise an awareness. Data and IT system, a separate institution of digital health management established, which is different parts from NHS, and will take over the functions next year, January. The quality assurance, though, there is a plan to establish methodological centers in the base of cancer centers, which will provide expertise to regional hospitals. And of course, the discussions with the Ministry of Health, how to particularly foster research and more active involvement in hospitals. So yes, since the project started, so we know a bit more about the actions, and now we are engaged currently in the CCI4EU, Jane, Crane, ECOS, EU on Call, and many others. The project helped us to create a future vision of the cancer infrastructure that should be comprehensive cancer infrastructure in model Latvia, and it should involve the majority of ministries, the patient organization, 2 university hospitals, 3 university hospitals, 2 regional hospitals, 2 university, and 2 research organizations. Well, and finally, so I would like to conclude. So this project was the first experience. It was the first project of its kind in Latvia, providing very high-quality, detailed gap analysis in covering all areas of oncology care and giving structured recommendations on improvement plans. So, and I think the key success was the highly experienced international expert team with excellent organizational skills, and who were able to bring all relevant stakeholders, like small pieces, in one and bring them to the table and start discussions. And this is the point the process has started. So the project has finished, but for now we've got a clear and strong vision of future directions towards comprehensive cancer care in Latvia. And Simon asked me to comments on what could be better or what was wrong. Well, actually, my comments, of course, we needed longer years, so we need more your expertise. Well, my suggestion will be to organize maybe follow-up visits and just to see, so where are we now? So where's the roadmap? And ask the governmental authorities, are they following the plan? Thank you.
Thank you. Thank you very much, Andres. Obviously, stay in touch, because we're just going to go for some questions now. And I had the privilege of being on that consultancy team, as Andres said. And that second point on your final slide about, I mean, in a way, we were acting as facilitators. And you saw the slide of there are 6 ministries involved in the challenge of high-quality cancer care and research. And in a sense, just to get people around the table together with the aid of EU money and an independent consultancy and say, what is the collective vision for the whole nation of Latvia across the patient pathway? And this is the kind of thing we would love to do more of in the CCI for EU project, in what we call the deep dives, which are being chosen over these next 2 weeks to those who've requested this deep kind of consultancy process, which will, again, be fully funded. There'll be much larger teams, actually, so there should be teams of 9 consultants, 9 or 10 consultants, over an 18-month period with 3 or 4 site visits, fully funded by the EU. So this is going to be really interesting, and what we hadn't put in place for Latvia, but we will put in place for CCI for you, is an evaluation metric of, what was the snapshot of the infrastructure before consultancy, what's the snapshot and evaluation at the end of the process. Did we make any difference, and is it sustainable? These are important questions for the EU to ask. And before really opening to questions, a tiny comment. The development of the home-based palliative care was because of the patients. I remember the workshop where the patients pretty much thumped the table and said, there is not enough provision for palliative care in Latvia, and it needs to be based at home where patients would most prefer to receive it. What are you doing about it? And the ministry were there. We reported back to the Minister of Health. But it was the patient momentum that made that change. So congrats to them. So any questions on this capacity building, either specific to Latvia, to questions to Andres, or to MEF as a consultant, or on the whole challenge of capacity building? Any questions, please? And a roving microphone will come to you. Peter.
First of all, congratulations. This is fantastic improvement in Latvia. My question is related to this palliative care at home for the patients. I really admire this initiative, and I wonder that it's relatively easier in a smaller country to achieve this kind of success. But I also envisaged that you had many challenges throughout implementing this activity. And I'm wondering, what were the challenges related to the funding and also the employment of the staff who were involved in this project, to give us advice how to do it in other countries?
Yeah. Well, actually, so the project was successful due to previous one, the pilot project, which was going on in one part of Latvia. So actually, they showed a good example that it works. It was evaluated by the patients and the involved specialists and organizers in the projects, where they were happy with the things and with financing. And so therefore, there was open application for all interested specialists and the teams who are willing to deliver this kind of care. I think the one point, of course, is financing. So, and the funds makes really big changes. And there were, I think, 8 or 9 applicants that fulfilled all these required functions, and they agreed to work. So beginning was a small pilot project, and then we spread it to all the Latvia. And I think with the bigger countries, so it could be the same, just starting from the one region, then spreading to other regions and making it comprehensive.
Thank you. And our experience is that there are so many different ways of organising this. First of all, through local authorities. It depends how the funding works, through local authorities based on a community level, or sometimes, as I visited a centre recently, actually palliative care teams from the hospital going out into the home and supporting patients in the last few weeks of their lives. So there are different ways, aren't there, of organising that depending on the context and the funding. Thank you for the question. Any other questions on capacity building or on the process in Latvia, the experience in Latvia? Because it's really good to focus on you don't call yourself a Central and Eastern European state. You're a Baltic state, but there are many from Central and Eastern European countries here, where capacity building, I think, is a real issue. Any questions? Well, we're going to be on time in that case. Thank you very much, Andres, for reporting back to us.